we're going to talk about what HCC coding actually is. And if you have probably heard about it, but have always been curious, we're going to answer some of those questions, hopefully. It is much more in your face than it was a decade ago, or I'd say about 5 years ago. It really started taking the mainstream coding world and taking over where people talked about it more often. But let's break it down so that if you hear or you have somebody ask you about it or you want more information, the right verbiage to use to look it up. The HCC stands for Hierarchical Condition Category, and that's why we say HCC instead. It is only one code set that's used. It's ICD-10-CM. We are only coding for diagnoses. And for the most part, it is only chronic conditions. It's not all diagnoses. So that's important to understand. The purpose was to be able to budget for the care of patients. Now, in the inpatient world, that's already done because you are paid with RVUs and stuff. The way you're paid is different than sending out a bill and billing the payer and then getting reimbursed for that, for the percentage that they pay. Instead, what you do in inpatient is that a diagnosis is submitted and everything is bundled for that diagnosis to treat the diagnosis. So if you have appendicitis, they know, well, you're going to have your appendix taken out, so you're going to have this surgery. They know the battery of tests that will be done before, during, and after, and any follow-up and global days and all their stuff. So it's a package deal. So we would say, this isn't the total, but we'll just say $10,000. And then if there's any complications in there, any additional diagnoses, it might be an extra 3, 5, or whatever. But it's all, you know how much is involved because it's a predetermined dollar amount so that you're able to budget for the care of that patient. So appendicitis would be, say, $10,000. A heart attack that needed bypass surgery, maybe $100,000. And that pays for the nurses and all the supplies that's needed during that time and staying in a bed for that amount of time. So that's an overview. Now, the origin came from CMS, and the CMS stands for Medicare and Medicaid Services, if you weren't aware, and Medicare Advantage plans. So that is, it's predominantly used with Medicare Advantage, or that's who hires a lot of people that specializes in HCC. And I want to also bring up a point that we in that world will say HCC coding, or we used to, but that's really not what it is. It's risk adjustment coding, and we're coding for HCCs. So it becomes slang. Therefore, if you type in HCC coding jobs, you may not find the jobs unless you use the word or the verbiage risk adjustment coding.
But it is good to know they're used interchangeably.
Correct. And depending on where you're looking, if you were just to Google it, you might get, say, a facility or an entity, an MA plan or something. But when you go in to look at the individual jobs of that entity, you may need to say risk adjustment or vice versa. So that's one thing to be aware of. Now, again, it's a budget.
I just wanted to jump in and explain, because I never did risk adjustment coding. Alicia has, so she knows way more about it. But what I do know is when I first got into coding, it was like outpatient or inpatient. And the big differentiator is what drives the money, what drives how they get paid. And in the inpatient world, it's the diagnoses. It's wrong with the patient. And Alicia just explained, based on the diagnosis, they know how much money they're going to get. And it incentivizes the hospital to be efficient with all the tests and everything so that they can make some money. And then in the outpatient world, it was traditionally the procedures they did drove the reimbursement. So the CPT codes were the main driver. So risk adjustment is like a hybrid of the two, where they're now trying to take this kind of managed type of way that they did it in the inpatient setting, now in the outpatient setting. Maybe that might help if you're brand new to this. I know that helped me when I was first learning about it. But
That's right. Understanding the purpose in what you're doing is important, I feel, because when I first started doing it, the rules are different. The guidelines are still there, but the rules are actually a little different, and it grades on your coding spidey senses when they ask you to do something different, but that's because of what the purpose of the job is or your role. And so you have to be adaptable, but we're adaptable as coders anyway. So the basics and the purposes is that it's a value based care model, and it's classified as risk adjustment. It's ultimately all about a budget, okay? And it ensures that you have accurate reimbursement for high risk patients, chronic conditions. So think of things that are chronic that would cost a lot to treat over a year's period of time. COPD, diabetes, and any type of Parkinson's disease, muscular neurological conditions, epilepsy, those big ones that probably take maintenance medication to maintain health. If it's chronic, it probably carries an HCC. I'm going to tell you what the HCC is in a moment, but do know that the purpose is to create this comprehensive documentation of the chronic conditions that a patient has over a year's period of time. And it's not just chronic, it also is complex. So let's say that a patient gets pancreatitis. If you're a diabetic and you get pancreatitis, then that's two diagnoses that is driving that patient. This is an example of the different categories that HCCs are put in. When I first started, I think it was version 17, maybe 16 or 17. It was soon 18. They don't put out a new version every year. There's big gaps in between the versions. So now we're in 28. And I would say about every 3 years, 3 to 4 years, I think, is an average that you get a new version. There isn't a set time for a new version. So it's not like the code sets that we use, or we get a new code set update every year. It's different. So it's not just the HCCs, which is a term that holds value to a diagnosis in a category. It is more than that. Is also the algorithm that they use to determine the dollar amount for a diagnosis. So if a patient's had, for example, COPD, it may be a value for a year to treat that patient, that HCC code is given, versus a patient who has emphysema, okay, because that's that next stage. And then the next version, COPD, may be more or less in reimbursement based on all kinds of factors. But ultimately, what we're trying to do is, for the category that the HCC falls in, and you can see this here, the first one is other thrombophilia, yeah, due to AFib. So you have a patient that has AFib and then they're clotting. And that diagnosis, here we have a category, HCC category. So which group or block they put it in, that says 48. Is it a HCC category? No. But then it holds value. But look at the one underneath it. Type 2 diabetes with polyneuropathy. That's an HCC of 18. It's in the category 37. And then there's dollar amounts that it's worth, a percentage. Now, As I'm telling you that, I don't want you to start getting upset because there's really no math involved here. Although it will appear that there's math, the math is all done for you. And a lot of times you don't even look at the coefficients for that category, for that version. It's all done by the computer unless you get into the analytical side of risk adjustment. And some of you may want to do that in the future. But here, this gives you an example of the categories that a diagnosis code would fall into, and then how that coefficient is the value that's placed on that. And I can even show you, if we have time, we can go into find a code and I can show you a calculator that they have that's involved with that. Let's go to the next slide and let's talk about the impact of scores and payments. So what we end up doing is taking all of the diagnoses and we put them in a RAF score. This is another term or verbiage that you, if you're going to get into risk adjustment, that you need to be familiar with. And that is a risk adjustment factor. So that's taking all of the diagnoses that a patient has. It also includes if you're male or female, and it includes your age. So if you have a 65-year-old patient and they're female, and we'll just keep going with we'll go here, we've got CHF. So you have CHF. And that patient they're going to set aside an X amount of money to take care of that patient for the coming year. And another thing about risk adjustment is it's always retro. So the year that we're in now, we're pulling all of the diagnoses from the previous year. And that's why specificity is extremely important with this. Now, the example we're given is, look in option 1. You have obesity. Obesity does not have an HCC. Okay? So we're not setting money aside for obesity. However, if you're morbidly obese and you have a BMI over 40 and they use the E6601 or the class 3 code now, either one of those, that does have an HCC. So money is set aside for option 2 patient because of the specificity, not for option 1 because it doesn't carry a RAF score. It is not a diagnosis that has an HCC. These are predetermined what carries an HCC. And I think in most manuals now, diagnoses, they even have the HCCs off to the side by the codes that risk adjust. If a patient has type 2 diabetes and they have retinopathy, then they get a value of 0.104.0, which again interprets into a dollar amount. That is not as specific if you have with diabetic retinopathy. That is 0.318. So you can see that 0.104 in an equation is not going to hold value as much as 3.318. Now, as we look at these other codes, I won't go through all of them, but I do want to bring up that now, if you have multiple diagnoses that compound each other or exacerbate each other, they recognize that. So they give you, I call it a bonus, but a little uptick in the risk scores. So the first patient has both CHF and diabetes. So they're going to get an additional 1.154 added to their RAF score. So they get more money because when you have a diabetic patient that's CHF, both those diagnoses is going to be more complex. It's going to take more money to budget for that patient. However, look over here in the option 2, the patient has CHF, diabetes, and COPD. So with those diagnoses, they get 0.154.19. And actually, it's more than that, but that's a little bonus on top of everything they get because they have combined diagnoses. So you think, why is that important? One, we're budgeting for the diagnoses and the complexity to care for that patient. If the person who's capturing the HCCs looks at the documentation and doesn't get the specificity, and they have a patient with type 2 diabetes, but they don't say type 2 diabetes with retinopathy, neuropathy, CKD, things like that, you can see how that money will go down. And yet they'll still have to have that care. And the Medicare Advantage plans look at that very carefully, because they need to know that they're going to set aside the money needed to take care of that patient in the coming year. They're banking for that patient's care because they know specific diagnoses take this amount of money to take care of, and that have more complications as you get combo codes and stuff like that. The lower the RAF score, the less money that's set aside for the patient. The higher the RAF score, the more money that's set aside. And they want to make sure that they have coders who capture these HCCs accurately. And that's why they created a certification. Let's move to the next slide and let's see what some of the criteria is when you're capturing the HCCs. Now, we have a term that's called MEET in risk adjustment, but I have to tell you that it is now a mainstream term, and it's used in everyday coding, because just when you look at the documentation for a patient having an office visit, and the doctor states that the patient has diabetes, obesity, and hypertension in the A&P, the problem, the plan and care of the patient, which is usually at the bottom of the documentation. If they don't tell you what they're doing about it, you can't actually code for that. You have to have a thread. In risk adjustment, you have to be able to prove the diagnosis. And if you can't, then it gets tossed out. And the key thing about risk adjustment is everything's wiped clean on January 1st. So let's say you have a patient that has all the diagnoses that we looked on that last slide. On January 1st, all of those diagnoses get wiped clean. You have to recapture them. And that even includes people with like an amputation. They have a below the knee amputation and it was due to diabetes, gangrene. It doesn't count. Again, the guy's leg grew back as far as CMS is concerned. So again, you've got to get it right. You've got to be consistent. And that money will not be set aside. So you want to have meat to prove the patient has it. I call it a golden thread, linking the diagnosis to however it's being monitored, evaluated, assessed, or treated. And this is, again, a mainstream term now in coding. If a patient comes in for an office visit and they have cerumen buildup in the ear, then the doctor has to state what they're going to do about it. If they just tell them, go get some D-Brox and put in your ear every night for a week, that's saying that's how we're going to treat it. If he states that he looked in the ears and both ears were impacted, that's an assessment. There's a line there. If he evaluated the patient's hearing and said, you're not hearing too well, you've been having problems with your ears, and you say, yeah, it just seems like this last year I've had more and more trouble. So that's evaluating. He goes and he looks and he goes, you got impacted eardrums. If he's monitoring it, he says, you know what, I'm going to have you go use this D-Brox, and then let's come back in 2 weeks. And if that has not flushed, if you haven't been able to get that to flush out, we'll come in and do it here in the office. Now, that's something simple, earwax, but that also applies to a patient that has emphysema. What about Parkinson's disease, cerebral palsy, all these diagnoses that have to be monitored? Just because the doctor says they've got it, we've got to prove they're doing something about it. And so MEET is something I would write down and I would get familiar with, because it's an everyday term now in coding. We want to always find specificity. We want to see that the most specific diagnosis is used. A patient that is a COPDer and gets emphysema, there's multiple types of emphysema. Are they lobular emphysema? If they are, then you don't code it as the J44.9 COPD, you're going to code it as the J43, whichever one is lobular, which I think it's 3, I'm not sure, because that's more specific. If a patient has diabetes and they have CKD, there's a combo code for that. So you end up coding like type 2 E11.22 because they have diabetes. Then you've got to code the CKD, then code the CKD stage in 8.4, stage 4. And so that specificity is very important in risk adjustment. The meet criteria is equally as important. Got to see that golden thread showing what's being done about it or proving that the patient has it. And then again, every year, these diagnoses have to be captured again, and they have to be captured on a face-to-face encounter. Now, face-to-face also includes telehealth. It does not include telephone only. You have to have audio visual. They change that off and on throughout the year, things weighing and different rules change. But the last time that I checked in, they'll do telehealth, but telehealth rules just changed again. So you're probably not going to see that as much. And one more thing about this that you need to know is that if you're working for an MA plan, you'll look at a year's worth of documentation for one patient. And this will be a patient that you don't know. And you will not know the provider or the clinician who's treating that patient. So I would sit down at my desk and there would be uploaded into the platform to grab 6,000 patients. And we would all just wait for the next patient to queue up, and you'd open up their documentation and it might be 30 pages or 600 pages or 2,000 pages that you would go through. And a lot of that was fodder because it has to be a face-to-face encounter within that year time period. But all that stuff back then was all scanned in, and you would have pages that were flipped upside down. Sometimes pages were cut in half because they were folded when they were scanned and stuff. That doesn't happen as much nowadays. A lot of it was handwritten. Again, you don't see that as much either. But you do have to go through that page, know what you cannot capture an HCC from, so you can do it from the therapies. That means you need to be able to read a physical therapy note or a speech note. You need to be able to read not laboratory tests, but imaging, radiology exams, op reports, inpatient encounters, outpatient. So can you tell the documentation from an ER visit what documentation is from the nurses and what documentation is from the physician or the NP or the PA? Because not all you're allowed to grab an HCC from. So again, it has to be an approved provider, which would be MD, DO, NP, PA, or therapist or medical social worker. That's predominantly all. Dietitians that have their masters, I think you can. Again, if you're going through 1,000 pages, a lot of times you just flip. Oh, I can read off that documentation. You got to scan it and you grab the diagnoses that have meat, and then you're going to be loading that all into an Excel page. That's what MA work for risk adjustment tends to be. Or you could work for a hospital system. If you're working for a hospital system, you're preparing and making sure all the diagnoses are captured for that patient before it even gets sent to the payers and the MA plans. So you're making sure that meat is captured. You're making sure that diagnoses at the highest specificity are captured, et cetera. And you work routinely with a lot of spreadsheets, Excel sheets. Okay, so moving to the next common challenges that we end up seeing with the next slide is that the challenge is incomplete documentation. You've got to be able to see and determine if out of that 1,000 pages, which is an approved document by an approved clinician or provider. And then say you're going through and you're looking out of it, and all of a sudden you realize that doesn't have a proper e-signature. That one doesn't work. They used to have stamps back in the day. You couldn't have a stamp signature. It would get tossed. And so little things like that you probably don't run in today. But what if it said, if verified by, and then the doctor's name, their credential has to be on there, the date, the time, so on and so forth. So you have to learn what e-signatures look like, which are ones that were viewed versus verified. Viewed doesn't mean they signed off on it. That just means that they looked at that document that day. Verified is signed. Sometimes it'll say e-signature. There's 10 or to 20 ways that different entities set up their EMR systems to sign for the doctor to sign. Sometimes their signature is the top of the document versus the bottom of the document. Then you have to look for addendums. So that's all this stuff that's really a lot of CDI work, actually, that has to be under your belt. You have to be good at that. Outdated problem lists. We could code from the problem list if we could prove that was an active diagnosis. So that's not how you work in the trenches every day coding for outpatient services. You're just coding for what was being done that day for that patient. So if a patient was a diabetic and was coming in to have cerumen cleaned out of their ears, and you could see that they were on a diabetic medication and their diabetes is in the problem list, and everything, there's ways to link all of that and see that. You have to know the medications to treat certain diagnoses. How do you know that the patient has hypothyroidism? The medications that they're being treated for, you can see that in the med list and stuff. So you can see how it's a multifaceted skill set. You have to be good at the pathophysiology. You have to be good at pharmacology. You have to be CDI, and you can read documentation, all encompassed in reading these encounters. You have to have provider unawareness. They don't realize that they have to document to specificity to be able to capture HCCs, because that's not really why the patient was there. So again, your role is capturing their chronic conditions throughout a whole year, not just everyday encounters. And the model versions change. We're already on 28, and I told you I started and it was like 16. And then if you know that they're not changing them every year. The impact, if we miss the HCCs, the diagnoses that carry weight, then the patient's RAF score goes down, and that money's not set aside for the patient. So then the clinician doesn't get paid, the physician, and neither does the payer, which is Medicaid or Medicare. There's Medicaid and Medicare have an HCC program. So they're going to be upset with everybody. Ultimately, for incomplete documentation, we want to train our providers or clinicians how to use templates and tools. Like Epic has a great HCC tool that will go back in 3 years of all the HCC diagnoses the patient has had and tell you if it was captured that year yet. And so then the family practitioner can come up and say, oh, you have a toe amputation. It hasn't been captured yet, and you're a diabetic. And you know what? When they come in, they can ask about it and then document on it and say, how is that going? Have you had any problems with walking? Let's check your feet. Or it's time to go to a podiatrist. You're diabetic. You need to be getting your toenails trimmed by a podiatrist, and they refer them to get that done. That's also taken care of it. With the outdated problem list, make sure that there's no incorrect coding, and you have to do audits constantly. The coders are audited, the auditors are audited, the docs are audited, everybody's audited, because it's a lot of money, and you want to constantly improve, and you want to be updated of any changes. Coders lack detail a lot of times, so ongoing education is really important, to have huddles and keep everybody up to date. And then with those payment shift, when I started, an old MI carried an HCC, and then a year later it didn't. And you're so used to looking and capturing that, and then all of a sudden they're not paying for it anymore. It's like, oh, it's frustrating. Or things that you didn't think would be. I think OSA should be on there, because that costs a lot to treat patients with obstructive sleep apnea. Someday it'll become an HCC. So monitoring CMS for updates and adjusting the codings as we go to the next slide, we're going to talk about tips for accuracy. And that is extremely important, because you're not going to be good at the beginning. So there's a lot of things you have to do, right? So you have, again, pharmacology. Pathophysiology, you have to understand the disease process. You can see a patient that's having gastric issues and digestive issues and follow them through all the testing and everything. And then maybe they have cancer, and then all through that treatment of the cancer, and then maybe they end up getting a stoma, which risk adjusts and stuff like that. And then they have a takedown where they put everything back together and just go. You would understand the disease process, the flow of treatments, what treatments is common for these diagnoses besides medication. You also want to, besides increasing your education, you want to make sure that you're working for a company that takes the time to do auditing for you, auditing for the clinicians. If MA plans, you're not going to see the audits for the clinicians. Now, big entities will have HCC or risk adjustment programs. So that maximizes their money. If they have the clinicians trained on diagnoses and risk adjustment, and then the auditors that are specifically looking that over and auditing both the coders and the clinicians, and just like this revolving auditing fail-safe being done, then more money will be given to the entity for the care of that patient. The ultimate goal is making sure the patient gets what they need, and then provide education for the docs on NEAT. Don't just say the person has the diagnosis. Tell us what you're doing about it. Keep the problem list current, and that's incredibly hard to do. That is the bane of most coders, is the problems list is never updated or accurate. So a patient has a problem list where they had rhinitis for the last 3 years, and it was from hay fever 3 years ago, but it's still on the problem list and considered active because nobody took the time to take it off. Use technology, the EHR systems. Like I said, Epic has a great one, NLP tools, and identified missed conditions. Educate everybody on the team. Like I said, old MIs, there's specific documentation and reasons, and that would be captured. It's not probably going to be captured on a regular office visit unless there's an issue. Now, it doesn't risk adjust now, but that's an example that popped into my head. But if that patient, like an amputation, a toe amputation, isn't necessarily going to be captured unless the patient has a reason to take their shoe off. And we need to make sure that the clinicians know what risk adjusts and why it's important to be capturing them, especially on annual wellness visits. That's like the prime time to capture chronic conditions. Our next slide gives us the 10 commonly missed HCC codes. Metastatic cancers and acute leukemia. It's really funny because leukemia is just leukemia unspecified is the lowest risk adjustment scored cancer. If you give specificity to the type of leukemia, it becomes one of the highest. And so that shows you how important specificity is. Let's see, anytime you have cancer that is active or has metastasized, by the time it moves, it risk adjusts very high. And it really changes the RAF score. The RAF score goes through the roof for those. Pressure ulcers, if there's not complete staging for them, then you're not going to be reimbursed. And pressure ulcers take forever for these patients to heal and compromise the patient. And they usually have other chronic conditions as comorbidities that caused that to happen. Severe hematological disorders, there's complex coding regarding them. Just look how many anemia pages you have in your manual. 10 pages for just anemia. It doesn't usually get covered a lot unless the patient gets put in the hospital and then they mention the patient has anemia. Cystic fibrosis, it's rare, but it is a chronic condition, and it's often overlooked on the annual wellness visit unless the patient's got a problem. Atherosclerosis is so common, but when you have atherosclerosis with ulceration or gangrene, that is through the roof. So that's another one where specificity really counts. If you live long enough, you're going to get atherosclerosis. But again, ulcerations and death of that tissue is huge. And then respiratory dependence on tracheotomy statuses. So when a patient is on oxygen full time, that risk adjusts very high, as well as anybody having an artificial opening, any type of ostomy of any type. Tracheotomy is one that's overlooked, but also colonoscopy. I don't want colonostomy. What am I trying? They have a stoma. Any stomas will risk adjust. So the next is the most commonly missed part 2, or is that the same? No, you just haven't changed the slide yet. Is that the same as the other one? On the next slide, Laureen? Are those 2 slides the same? Oh, there it is. There, you did it. No. Okay, so the tracheostomy, dependence, oxygen, ostomies, any artificial opening, urostomy, a lot of times that's overlooked. Transplant status, kidneys, but think of all the things that can be transplanted. So kidneys, we think about that because it's talked about, but you can have a liver transplant, a lung transplant. There are some other that stem cells and stuff like that. They are often confused as complications, and that's not what they are. Transplant status means that you're on medication for the rest of your life. And so you may be healthy and doing well, but it takes a lot of money to care for a transplant patient because of the pharmacy aspect and the possibility of other complications. Obesity, again, very common, often left off, but it complicates everything. You got to have a procedure and you're morbidly obese, and especially if it's like a spine surgery, they got to flip you around on the table or any orthopedic thing. That makes you more complex of a patient, and it usually exacerbates other conditions. Long-term use of insulin, diabetic medication is extreme. Z79.4 is always overlooked and needs to be captured every year. So that ends us with risk adjustment. Do you want to take a moment, Laureen? Do I want to look at the questions or?
Yes, we have some questions. So let me see. I think I'll just take this off and show us. Okay, so let's start with this. This is just a comment, but I thought it was interesting.
No procedures is my favorite part of risk adjustment coding. Okay, I have to tell you that which you already know this, I'm not a fan of CPT. I don't think it's a very good code set. ICD is a brilliant code set. And yes, ICD-10 PCS was for procedures, but you're right. There is no procedures. Now you do need to know them. You need to know what is the cause of an effect. How are they going to treat a patient that has these diagnoses so that you can capture them, but you don't have to code for them. So that's brilliant. I'm here to understand why I'm doing it.
You'll have to let us know, Anne-Marie, if she helped you figure that out. If not, let us know and she can clarify a bit more.
Ultimately, it's about everything boils down to the patient, right? Taking better care of the patient. How do we take better care of the patient? We budget for the care of the patient. How do we budget for the care of the patient? Then we look at the past year to plan the budget, right? Just like if you did that in your home, how much did we spend last year? What happened last year that we weren't expecting? What do we need to budget for this year and the coming year? So that's all it is. It's really about budgeting. People think it's risk adjustment for patient, but it's the risk adjustment for the insurance. It is true, but it's more than that, because if we don't capture all the diagnoses for that patient with the highest specificity, again, the facility or whoever their primary care doctor, all the specialists, every time they go to the hospital, every time they get lab drawn, all that money's not going to be there. Now, yes, it's also how your doctors get paid a lot of money. They don't get paid as they turn in a bill. So if you have the plumber come out and he fixed your toilet, he's going to give you a bill and you're going to pay him. He's instantly paid. Okay. Now, your insurance company, how do they get paid? You either pay monthly or you can pay for a whole year. And they send out with risk adjustment a lump sum every year. instead of paying that plumber $250 to come in and fix that job, he's getting paid for a whole year at a time. And for all of the patient or all the people that he sees, he's getting written one check. And so you can imagine how important that is to the clinicians and the facilities and stuff. They bank on that check. So they're going to get for that, for all of the appendectomies, risk adjustment works for Medicaid and Medicare. And now mainstream payers do it too. But we're talking about millions of dollars that come into the hospitals in one lump sum. That's another reason why they want to get it right. If see, do you submit claims for risk adjustment? It's different. No, you don't submit claims like on a 1500 form or a B form. What you're going to do is you're putting the HCCs in. So you're putting the diagnoses. The program recognizes what diagnosis is matched to which HCC, like type 2 diabetes, no complications, is a 19. And then if they have a complications, it's an 18. And it might be a 17 if it's got XYZ, something really rare. But 19 gets paid X amount of money. But if you're an 18, you get paid even more, right? Those HCCs get sent out for that patient, and there's an algorithm that's used that determines how much based on male or female, your age. So of course, it costs more to take care of women than it does men. And it also, can you imagine how much money you need to pay for a 65-year-old with COPD versus an 85-year-old with COPD, right? So the 85-year-old is going to need more money based on what we know. So it's a lot of statistics, and it all goes into a database and a statistical program, an algorithm. And if you like statistics, there's a lot of room for you to do this type of thing. And it's monitored very heavily because they got to get it right. No, you don't send in claims. It's all computerized. And can you imagine how AI is brilliant at this? So this is a huge way to work AI in it. HCCs, if I have a chart with a diagnosis that doesn't have an HCC value and it's placed in A&P, do I have to code it? No, or not? I'm confused. Okay, so if you're working risk adjustment, you don't code anything that doesn't carry an HCC. Now, there's more than one type of HCC. There's prescription HCCs, which is called an RX HCC. There's an end-stage renal disease HCC, and there's the mainstream HCC like the V28. Your role is to capture only the diagnoses that carry an HCC. You pretty much get them memorized. Again, old MI used to count, and now it doesn't. So they tweak and take things on and off at different times. The other thing is, again, like leukemia, unspecified, very low HCC. Leukemia with, let's see, what's it called? B cell something or something, really high, because leukemia doesn't go away. And again, big difference in those. But the fact that the patient has hypertension, that's an RX-HCC, but not a regular other HCC. Things that aren't chronic don't risk adjust. Asthma doesn't risk adjust, but COPD and emphysema does. If you break your leg, that doesn't risk adjust for MA plans. Now, it would for Medicaid. Okay, so the two models are different there. If you're doing MA plans, Medicaid, chronic conditions, only 65 years and older, or they're on Medicare because they have a disability. And then Medicaid, state driven, they capture HCCs. So you will have babies, children, mothers giving birth, all that stuff, because they're budgeting their populace who they're treating.
So we got a few thank yous here I wanted to share. Thank you for that explanation of how HCC risk adjustment work. Your explanation made it so much easier to understand. And yeah, I found myself actually.
And that's why when you're told to do something and your experience is either in school or working some jobs, and then you go into risk adjustment, it's a different type of coding. So things that you're allowed to do is different, or they may tell you to do something. Like they may say, okay, today don't collect any RX HCCs, only collect the other HCCs, and then the next day they say, okay, on all the pulls that you're doing today, you're going to do both. Or I'm going to move you to end-stage renal disease. So now you're only capturing end-stage renal. So they could be moving you around depending on the contract that they have. So you have to be adaptable. You do get to learn. Oh, old MI is now an RX HCC. Okay, good to know. Because if you had a heart attack, you got to be monitored. It costs money to take care of a patient. Each payer is different. That's right. If you're working for an MA plan and you're working for Humana or Blue Cross Blue Shield or UHC, each one of those may have specific rules about things that they do and do not use. And they have like error and omission codes that you have to put in that says, okay, I went through 30 pages, but 4 of those pages weren't signed, or XYZ, or I can't read that page. There's all kinds of things that you do but if they take the time to tell you why you do what you do, then it makes it a lot easier.
Alicia, can you speak to, because this has come up before, when this is someone's very first job, let's just say they took our CRC course and passed their certification and they get their first job, what should they expect and how can they really set themselves up for success?
Okay. The very first thing I would tell you is know that you don't know everything. And risk adjustment, for example, is a great starter for several reasons. One is they usually are willing to train you, right? It's very unique. So they'll hire new coders for their first time job, but know that you're going to have somebody looking over your shoulder a lot, which is a good thing. All right. So you want that. They're going to hold your hand and train you. You want to have a positive attitude. And look what it's going to teach you. You're going to look at documentation from all over the United States so that when later you get another job and you're looking at 3 doctors or even 20 doctors, you get to know their documentation. You almost become nose blind, right? You know where everything is on that document. So it teaches you to be fast. It teaches you to scrutinize and abstract quickly over all types of things. There were people that I was working with who had never seen a physical therapy note before in their life. And so they didn't know how that it was based on time and where the diagnoses were and how to validate it. So all of that stuff, you learn that. You learn so much about the disease process and pharmacology. I knew about drugs. I could look at the problem or the drug list and I could tell you what diagnoses they had just looking at the medication. So you get an influx of knowledge very fast, which you should be grateful for, relish in that. You'll be slow at first and they expect that. But the qualities that you learn as a risk adjustment coder are going to pay tenfold for your career in the future, even if you don't stay in that realm. It is a real in the trenches job. And I would hire a risk person that's been a newbie risk adjustment coder, even if they didn't do it very long. That's another thing you have to be aware of, especially when you're new. Chances are you won't be working very long at a time.
Right.
Do not feel bad if you're let go, because one thing, it's contract driven. So they may say, we have 20,000 patients that we have to get through. The sooner we get through them, that contract ends. But we have a deadline and you've got to get them done by this time. There's different pulls. The end of the year is real busy, but guess what? You're probably going to be laid off in November and December because they're wrapping up and the pulls don't start till January 1st. And so you'll be let go right before Christmas. We'll plan for that. And that's if you work for an MA plan. But then they may say, hey, you were so good and such a positive attitude, willing to learn. We got this little side contract for end-stage renal disease or end-stage CHF. We'd like to pull you over here and pull you to do that. You also learn to work with platforms and programs that most people don't get involved with. You get to read intense reports like heart transplants. Most people don't get to do that as a coder. And podiatry notes, it's really exciting. Again, yeah, Anne Marie's right. There's sweeps at the end of the year. So you're really busy before Halloween, and through Halloween, they're pushing you overtime. We'll pay as much overtime as you're willing to put in. And then all of a sudden, like November 14th, oh, we're done. you're being let go for that contract. Also, productivity and accuracy rate, it is really different. Actually, a 30-page patient is a lot harder to get through than a 600-page, because most of that 600 is fodder. If they've got a 600-page in a year of documentation, that means they've been in and out of the hospital a lot, have a lot of that, like all of your labs, all of those EKGs, all that stuff would get scanned in and you'd have to look at it. So you would flip through 100 pages that you don't even need to pull anything from, and you can do it real, real quick. So that's 30 pages are somebody that was real intense and over a shorter period of time. And yeah, fluff makes it go much faster. There were some people that you got in trouble for this. You would pull up a patient and it would say 642 pages and they would skip it. Anne Marie was saying, guess what? If you skip it because I pulled them and now I realize I need to go take a break or whatever reason, or, hey, I've only got 30 minutes for that, so I'm not going to open that one because then it would be tied up. You can excuse, but if you only skip the hard ones, they get called out. They're constantly looking over your shoulder for a reason. And that's the other thing I see for an advantage. When you're a risk adjustment coder, you get used to that oversight, which is a very positive thing. And that makes you better and faster more quickly because they tell you your mistakes. Got it. You correct it. You move on. You don't make that mistake again. And when you go work for somebody else, you're, what's that term when you're not soft anymore? You're not, if somebody tells you that you've done something incorrectly, you don't mope about it or get upset. You've already been through the fire. You know that's a good thing. And so it's very positive. Yeah, you can't skip the chart, but you can skip pages if it's fluff. Okay, you're right. Yeah. But in the program that we were in, I've done it two ways, where there's a program that brings up the patient list. You pick that you're open and it's random, and you can see other people are working at the same time, and you're putting all of the diagnoses for that patient, pertinent information. So you do a lot of typing, data entry. That may have gone by the wayside now because it probably brings up the patient and preloads a lot of that stuff for you, and then you audit, abstract the diagnoses, and then you send it off, and with any errors and omission, explain why. You make little notes about what the meat was a lot of times. Or you could be working on spreadsheets, because if the platform goes down or there's a problem, they'll say, okay, here's your spreadsheet. And so that means you're working in Excel, and you need to know the basics of Excel. I work in the Excel every single day, and most coders do. So get good and comfortable with Excel, with simple stuff like how to delete a column or a row, how to wrap the content in one cell so it doesn't line up, how to change font, all these little basic things. You don't necessarily have to make pivot tables and all that other stuff, but be comfortable with it.
Do you feel like making risk adjustment is a viable full-time job, or is it better to be used as a extra income? Like I view risk adjustment as a great starter job, and then go get your CPT training if you haven't done it, and be a more well-rounded coder so you could do all types of jobs. And the more stable, full-time with bennies kind of jobs is probably going to involve CPT and ICD. But then you always got risk adjustment for that end of the year push to get that like extra income. Do you find most of the risk adjustment, you don't have to work during set hours, but you need to get a set amount of productivity done?
That is a great point. With risk adjustment, they usually don't care what time of day you work, as long as you get your hours in, and your hours is based on productivity. Okay, so you're going to be slow at first, and they expect that. So they give you a time frame. By this amount of time, we want you to be passing your audits at this percent, because risk adjustment isn't like other coding where you have to have 95% accuracy. You're 99% accuracy, because this is big bucks. But again, you're only working with one code set, no modifiers, none of that other stuff. That's one thing to be aware of. productivity. Back when I was doing it, we had to get so many in an hour, and we had to be able to do, I think, 4 to 5 in an hour. So remember, you're looking at a year's worth of documentation. So how many pages and Anne-Marie may know because she's obviously doing it. It also depended, are you loading it onto Excel sheets or do you have a platform program? They would take into consideration if you did in 1 hour, you pulled like 4,000 page charts. They can see all that. You're being tracked. But you can work in the evenings, you can work early in the morning and get done. They want you to meet or exceed so many in a day or per hour per se. And everybody's a little bit different. Now that's an MA plan in the trenches there. When I was doing it, it was unheard of to have risk adjustment jobs that weren't an MA plan, which would be like Optum. That's UHC. It's one of the biggest. Now, though, hospital systems have full HCC programs, especially teaching hospitals and stuff. When I worked for Baylor Scott and White, it was a risk adjustment program. And so that was different. I was pre-auditing, in other words, before it got sent to the MA plan, so that they knew for a fact that everything was captured for that patient. And then we were educating the doctors on, hey, these HCCs weren't captured or they needed to have meet. This is how you would document, so on and so forth, and the importance of it. I think it's a great beginner job because it gives you such a wide range of skill set. You can start out slow. There's a lot of grace given, and you can always pick up contracts after you've got another job. So if you say, I can only commit to 20 hours, 32 hours, or it's easy to carry 2 full-time jobs when you're doing risk adjustment and something else. You know what I mean? You could work part-time, get your skills with CPT. The other thing is that outside doctor's offices and outpatient, you really only have to learn E&M because you've already got the diagnosis, and everything else, there's just a few other things. So you're already halfway there. You're seasoned because you know the medical field. You're just picking up E&M. Although I will have to say that if you have the CRC, you cannot usually get a job other than risk adjustment because you only are certified in one code set. However, if you do that, you get your job, you get all that seasoning, you go pick up the CPT, you can work anywhere. Some people choose, I'm going to go ahead and get my CPT or CPC, sorry, I'm saying it wrong. And you can do risk adjustment, but nowadays, predominantly, they want you to be a risk adjustment, a CRC to get a risk adjustment job. Does that answer the question adequately?
I say so. Someone asks, is there a certification for a risk adjustment? Why, yes, there is. And we have a course to help you prepare for it. And Alicia is the instructor. I put the link in the chat and check it out. We're obviously not going to do the other generic.
Oh my word, look what time it is.
That's what I wanted.
Okay.
A lot of people really wanted this information, so this is good. I just want to go real quick to our slide deck to share a few more things. And let me turn off.
Anne-Marie said, for my job, we only need to be a certified coder. Just so you know, if you are a certified coder, they will hire you in risk adjustment. A lot of the times are changed now that there's a risk adjustment credential, they want that. But as a risk adjustment credentialed only, that limits your jobs. Just know that. So you got to decide what works best for you at this time.
But it's a great icebreaker to get the first job, break the seal. So now on your resume, it's, yes, you have experience.
So,
and yeah,
learn how to read all kinds of documentation. You learn how to do production coding. You learn disease process. And there's so many advantages that working for another entity is going to be a whole lot easier if you've already got those seasoned skills. Yeah.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.